course, all the invited guests. First of all, let's praise the God, the most gracious, the most merciful, the creator and sustainer of the universe. Praise be upon Muhammad Sallallahu Alaihi Wasallam, the last messenger of Allah, who has guided human life from the distraction into the right way of Islam. Ladies and gentlemen, my name is Vita Lestari Ayuningsi from Medical Faculty, University of Malahayati 2017. It is an awesome and precious chance for me to be your master of ceremony on this morning on Wednesday, 16 September 2020. In our big event, online seminar on language for a specific purpose team on English for medicine. Let me deliver the structure of this event today as follows. Opening, National Anthem Indonesia Raya, Malahayati University Anthem, the speeches, seminar, question and answer session, photograph, and closing. Ladies and gentlemen, before we start our agenda for today, let's open this event by saying Basmalah. Bismillahirrahmanirrahim. Ladies and gentlemen, the next step is singing National Anthem Indonesia Raya, and we'll continue sing Malahayati University Anthem. To Mr. Agung, time is yours.
Universitas Malahayati, selalu panjatkan syukur padamu, berkat rahmat dan karunia-Mu, hiduplah Malahayati. Alma mater yang kami cintai, jadikan kami harapan negeri, berkat bimbingan dari-Mu, Tuhan. Jayalah Malahayati, berkat bimbingan dari-Mu, Tuhan. Jayalah Malahayati.
Thank you to Mr. Agung. Excellencies, ladies and gentlemen, next on the following agenda are speech. The first speech from Mr. Slamet Widodo SS for reporting from Seminar C. To Mr. Slamet Widodo SS, time is yours.
Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Morning, everybody. The Honorable Pak Fari, as Director of Malahayati University. The Honorable Prof. Vijay Daniels from Medical Faculty, University of Alberta, Canada. The Honorable Professor Ibu Dr. Diah Kristina M.A. Ph.D. from Universitas Sebelas Maret. And then my beloved friend, Mr. Rudy, and all participants who have participated in this nice seminar. First of all, I want to say thanks to all participants who has registered to our event. We want to give a report for this seminar that we have more than 300 participants from every regions in Indonesia, from Sabang to Merauke. And then there are some countries such as Saudi Arabia, Thailand, Azerbaijan, and many other countries who have enrolled to this seminar. This online seminar will focus on teaching language for specific purposes, especially here English in medicine. University of Malahayati, there is one faculty that's medical. We have conduct English for specific purposes, especially English in medicine since 2008. And actually we have used methodology in teaching this ESV itself by using the book from Cambridge University Press, that's English in medicine, and also there is another book, good practice book from Cambridge University too. But in this case, we still have tried to find new formula or methodologies how to conduct teaching English in medicine itself, because we realize that we have goals for the future, how to create our graduations, have competition, have good skills in English based on their profession as medical practitioners. So by this event, by this seminar that's teaching English for specific purposes, especially English in medicine, we want to find out the solution how to teach English in medicine itself. So all the speakers really appreciate who has elaborate to our event today, and we hope that we can give like a new methodology or new paradigm how to conduct teaching English in medicine. As information that every semester we have more than 10 classes for English in medicine itself. And then we want to say to all the speakers that Malahayati University actually accept English in medicine itself. We have applied some English specific purposes also, such as English for business, English for law, English in engineering, and also English in nursing. So Malahayati has concern in developing English teaching methodologies itself, conducting Bilingual Center of Malahayati University. So in this nice occasions, I would like to say thank you very much to all committees who has create this event until today, especially for Mr. Rudy and teams, how to encourage our students to join in this event and all participants around Indonesia and also around the world. As the committee, we realize that in this event still weakness and many things that we don't need happen in this event, like we start late and others. So as the committees, we say so sorry. And I think that's all our speech as the chief of this event. Assalamualaikum warahmatullahi wabarakatuh. Good morning and have a nice day.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you to Mr. Slamet Widodo SS. The second speech from Rector of Malahayati University, Dr. Ahmad Faris MM. And afterward, we would like to request him to officially open the online seminar on language for specific purposes team English for medicine. To Dr. Ahmad Faris MM, time is yours.
Thanks, Vita. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Warahmatullahi wabarakatuh.
The Honorable Presenters of this online seminar, the Honorable Head of Language Center of Malahayati University, the Excellencies, all participants of the International Online Seminar on Language for Specific Purpose. Ladies and gentlemen, first of all, let's thank Allah Subhanahu wa Ta'ala, the God the most gracious, the most merciful. Salawat and salam may Allah give to the greatest Prophet Muhammad sallallahu alaihi wasallam. On behalf of the academic community of Malahayati University, I would like to welcome you all to the online seminar on language for specific purpose 2020, which focus on the theme of English for medicine. We are very glad to inform you all that this seminar has attracted more than 200 participants from many regions in Indonesia and other countries, from national and international institutions. Ladies and gentlemen, as we know that Malahayati University is the first privately funded university in the southern region of Sumatra to have a faculty of medicine. The first to have a teaching hospital incorporated within the structure of our university campus, ensure that students have first-hand knowledge and experience of current issues. Furthermore, this enables our students to have greater interpersonal skills with passion through practical experience. Ladies and gentlemen, allow me to express my deepest gratitude to those who have made this seminar possible. We thank God to all the committees, especially Language Center of Malahayati University team for this effort. I would like to thank the invite speaker, Professor Vijay Daniels, M.D., MHPE, FRCPC, DRCPS from Medical Faculty of University of Alberta, Canada, and Professor Dr. Diah Kristina, M.A. Ph.D. from Cultural Science Faculty of Sebelas Maret University, Surakarta, Indonesia, and the speaker Muhammad Rudy, M.Pd. from Malahayati University, Bandar Lampung, Indonesia. I welcome all speakers, presenters, and participants for this nice online seminar. I do hope this seminar can be one of the ways to provide and broad vista to develop new paradigm and understanding about English for specific purpose, especially English for medicine. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you to Dr. Ahmad Faris MM for the speech and officially opening online seminar on language for specific purposes team English for medicine. Well, ladies and gentlemen, now we will start our session on online seminar on language for specific purposes team English for medicine. This seminar will be moderated by Ms. Intan Hamzah, S.Pd. Intan Hamzah is an English instructor at Language Center of Malahayati University in Bandar Lampung, Lampung. She earned her bachelor's degree in English language teaching from Universitas Lampung in 2013 and pursuing her master's degree in Universitas Lampung. And prior to that, she was granted Fulbright Foreign Language Teaching Assistant Program in Northern Illinois University, USA, where she taught Indonesian language and performed Indonesian culture in USA, and studies language and literatures. Her current research is about negotiation of meaning, unfocused and focused tasks on medical students. To Miss Intan Hamzah, SPD, time is yours.
Thank you. Thank you very much for the Master of Ceremony. Good morning, everyone. I am Intan Hamzah, and I will be the moderator for the online seminar on language for specific purposes team, English for the medicines. But first thing first, I'd like to announce several rules for this seminar. The first is that the participants of this webinar are not allowed to turn the voice on during the sessions of the speakers, while the video are optional. And the second one is that there will be questions and answer sessions. Okay, so I will repeat for the second role. The second role is that there will be questions and answer sessions which will be divided into turns. Each turn consists of 3 questions, while the questions can be delivered through chat rooms by typing name of the institutions, and to whom the questions may concern, and your questions. And then as the time is limited, the questions will be randomly chosen by the moderator. In this case, the moderator is me. Okay, now I will welcome 3 excellent speakers. The first one is Professor Vijay Daniels, M.D, MHPE, FRCPC, DRCPSC from University of Alberta, Canada. And then Professor Dr. Diah Kristina, M.A. Ph.D. from Sebelas Maret University, Surakarta, Indonesia. And Mr. Muhammad Rudy, M.Pd. from Malahayati University, Bandar Lampung, Indonesia. For the first sessions, will be delivered by Professor Vijay Daniels, but I'd like to highlight the curriculum vitae of Professor Vijay Daniels. Professor Vijay Daniels, MD, MHPE, FRCPC, DRCPSC, works as a professor in University of Alberta, Faculty of Medicine and Dentistry. He got his bachelor's degree in biochemistry from University of British Columbia, Canada, and in medicine from University of Manitoba, Winnipeg, Canada. He got his resident in core internal medicine and general internal medicine residency, University of Alberta, Canada, and master's degree from Health Professions Education, University of Illinois at Chicago, United States of America in 2013. And then he successfully got licensure and certifications. One of them was on 2019 as the diplomat of the Royal College of Physicians and Surgeons of Canada in the area of focus competence clinician educator programs. And he also awarded 30 honors from 2009 until 2020 and 7 research grants with the total $219,300. His research focused on medicine, and his recent research is the Canadian Medical Student Ultrasound Curriculum, a statement from the Canadian Ultrasound Consensus for Undergraduate Medical Education Group on 2020, and the development of a critical care ultrasound curriculum using a mixed methods needs assessment and engagement of frontline healthcare professionals, published on August 2020. Today, Professor Vijay Daniels will be delivering one topic with the title, Patient-Centered Care on International Medical Graduates' Point of View. For Professor Vijay Daniels, time is yours.
Thank you very much for that introduction. I will share my screen. Okay. So I'm very pleased. Thank you to Muhammad Rudy for inviting me today. I see I have about 20 to 25 minutes, and I did try and time the talk, so it should meet the time requirement. Again, you've heard a bit about me. I don't have any disclosures, but I do want to acknowledge that some of these slides came from my colleague at University of Alberta, Dr. Roshan Abraham, who is a communications lead for our physicianship course in our medical school. So where am I? It is fascinating to hear that this is being delivered around the world, and Zoom is really quite an interesting thing to be able to do such a thing. This is where I am. You, I understand, are down here, and there's people all over the world, and I'm way up here. And in fact, Edmonton, Alberta, the city I am in, is one of the most northern cities in the world with a population of over 1 million. So it does get very cold in the winter time with lots of snow. Right now, it's okay. So the purpose of today, from my understanding, and I hope it does meet your needs, is to talk about communication skills. But as we know, communication skills in medicine is a very broad and complex topic. And in fact, we spend many hours across the first 2 years of medical school talking about this. So the focus of this talk is on those aspects with which I feel our international medical graduates struggle. So not just about what words to use in the English language, but how to put together the communication. And hopefully this will meet your needs this morning. So communication is part of the process of diagnosing a patient. We begin with the history, talking to the patient, finding why they came in. We move on to the physical exam, after which we then decide what kind of laboratory tests and imaging. And this cycles back to us explaining the diagnosis and management. So you can see communication is a very key part of the cycle. And when I was going through my education, I was told that 60% of the diagnosis comes from the history. If you ask my colleagues who are neurologists, brain specialists, they will say it's closer to 80 to 90%. And so communication is very important. One thing that is interesting is in North America, especially in the United States, but somewhat in Canada, where we can have lawsuits where physicians get sued for what we call malpractice, communication is the #1 reason. Not making the diagnosing correctly, not choosing the wrong management. It's communication that tends to be at the center of it all. So this is clearly a very important topic. But as you can see, communication is more than just the content. It is more than just which questions you ask. Because if it was just about what questions you asked, we would be getting in trouble because we made the diagnosis wrong. But that is not the problem. The problem is the process. Now you can see these diagrams that I'm using, it illustrates communication as a fairly linear concept, but it's not. We know that a good history can jump all over the place because we're listening to our patients. This brings us to the topic that I've been asked to speak on, is what is patient-centeredness, specifically more from a North American model, but I do believe it is generalizable around the world. So patient-centeredness is thought to have 5 dimensions of care. The first is what we call the biopsychosocial perspective, and that is that the non-medical factors influence the medical concerns. So I may be coming in with shortness of breath, or maybe I'm coming in with weight loss, but there's other things that are happening, troubles at work, my children, stress, all of these come together that impact how I experience my medical illness. Related is thinking of the patient as a person. So 100 years ago or longer, we used to just think of the patient as the object of medicine. We would do to the patient in order to help them. Whereas now we understand that every patient is different and they experience their disease differently. One big shift that has definitely happened over the last several decades is a shift in the power. What used to be what we call the parent-child model, we sometimes use the word paternalistic medicine, to more of a mutual participation model. And here are some pictures to kind of describe that. So an example I will use is thinking about in North America, if we were to talk to someone about smoking. In the old model, we would very sternly say, you must stop smoking. Smoking is bad for you. You may have a heart attack. Stop smoking. Whereas in a newer model, we understand that it's about collaborating with the patient. Asking the patient, do you have an interest in stopping smoking? If you do, what have you tried in the past? What are barriers? how can we work together to help you quit smoking? The therapeutic alliance, there's many things on this slide, and I see that Professor Diah will talk about this a bit in her talk, but empathy is key to it. Congruence, and the next one, unconditional positive regard. These are very fancy terms. Congruence is about the patient seeing their ideal self, how they want to be, and seeing how they are and the difference. Unconditional positive regard is a fancy way of saying treating your patients with respect and seeing them in a positive light. So even if that patient does not want to stop smoking, you do not get upset with them, you work with them and you see them in the best light possible. Patients' perceptive of effectiveness of interventions is obviously important. Agreement over the goals of treatment, what are we trying to do here, and the perception of doctor as caring. And this last part is probably the most important. One of the deans in our medical school said he had a patient once who said to him, "I do not care what the doctor knows until I know they care." And it's very key that our patients understand that we care about them. The last of the 5 dimensions is doctor as person. Attention by the doctor to the cues of the relationship as it develops. Especially when you see a patient time after time, you develop a relationship. But sometimes it can get a bit emotional, especially if you are frustrated that they won't sometimes take a certain therapy. And one of the key things is for us as doctors to be aware of our emotions, to then acknowledge you're feeling upset, and you need to remove that in order to take care of your patients as best as possible. So those are the 5 dimensions of patient-centered care. Now, in terms of patient-centered communication and how we incorporate it, there is evidence that it can improve the relationship with our patients, but more that it found positive relationships between patient-centered care, PCC, and patient satisfaction and well-being. They were happier with their doctors and they had a better sense of well-being overall. However, when they tried to look at harder outcomes, like better control of their blood pressure, diabetes, mortality, there were mixed results. Now, the thought is that the definition of patient-centered care differs between studies, and sometimes we're not always measuring the same thing. But we do believe for sure that there is a benefit in terms of the doctor-patient relationship. But the big question in a medical school is, how do we teach it? There are many frameworks that are out there, and I've seen many over my career, but at our university, we picked one model, the Macy model that comes out of the University of Massachusetts, and then we augmented that with other evidence-based models. I will warn you, the next slide is very busy, but don't worry, I'll walk you through the key parts of it. So do not worry if you cannot read that. I'm going to zoom in on a few places. But this is the respect communication framework. My colleague, Dr. Amy Tan, used to work with me at the University of Alberta. I was in charge of teaching physical exam. She was in charge of teaching communications. And she got recruited down to our University of Calgary, which is south of us in our province of Alberta. But she designed this framework that I'm going to walk you through a few areas. As you can see, there's 3 overarching categories. The first about gathering the information, the second building the relationship throughout the encounter, and the third is educating. And what I want to point out is this is not stepwise, that you first gather information, then you build relationship, then you educate. It goes back and forth throughout a history that you're building throughout. Let me first highlight a few key areas of the gathering information. Obviously, opening the interview, making sure you have permission, introducing yourself, and then you do find out the reason they came in, and you're going to go through your history or questions that I understand a lot of your curriculum is teaching. But 2 things I would like to highlight that many medical students, especially our international medical graduates, don't always do, is very clearly set the agenda. what is the purpose of today's visit? Because often what happens is you get to the end of your 10-minute, half-hour visit, and the patient is leaving and then turns around and says, actually, I have one more thing I want to talk about. And if you're a busy doctor, you have a lot of patients waiting. But the other one that I think is very important is summarizing frequently that you understand what's been happening. So if I take a history for weight loss and I'm seeing a patient, I will say to the patient, I am Dr. Daniels. I'm an internal medicine specialist. You have been referred to me because I understand you're having some weight loss. Is that correct? Yes, they will say. My job is to try and figure out what is the cause of this weight loss. Is there anything else you'd like to talk about today? That allows them to engage in a discussion, and usually they say no. And then as I'm taking the history, I may at a part say, so it sounds like you were well 6 months ago, and then over the last 6 months, you've been losing weight, having stomach upset, and you've been having looser bowel movements. And they may say yes, and then I will say, but it also sounds like it doesn't happen at nighttime, but it is associated with certain types of food. So we use the summarizing frequently to make sure we heard the patient and they understand they were heard. So coming back to our respect framework, and again, we spend many hours over 2 years teaching this. I'm tasked to do all of this in 20 minutes, hence I'm going quickly. In terms of building the relationship, the two things I really want to focus on that I still have many doctors in Canada forget is making sure they understand what the patient feels about their diagnosis and their symptoms. Sometimes that's asking them, is there anything specific you're concerned about? Many of my patients are concerned they have cancer, even though their symptoms is something that is not cancer. And asking them their concerns allows me to say, I understand you're concerned about that. I don't think it's that, but we will look into it. And then a very important one is exploring how this impacts the patient's life. We have patients who succumb to an illness, they've been sick for months, they lose their job, and we're too focused on the diagnosis, not finding out about what's going on. Because as doctors in Canada, we're sometimes part of what helps our patients get money so that they can, while they can't work, still be able to live. So another way I summarize this is the doctor has an agenda and the patient has an agenda. The doctor's agenda is, I want to figure out the diagnosis. The patient's agenda is, I want to be heard. And although these two do overlap most of the time, not always. And there is this back and forth between your agenda of figuring out the diagnosis and the patient's agenda of being heard. The way I often teach our medical students how to talk to patients is I describe 3 phases to the history taking. And I'm just going to be focusing on trying to diagnose the patient. The first is what I call the listener. This is where we ask questions that are called open-ended questions. Instead of yes-no questions, it's questions more like, first, I'd like to begin with what brings you in. What else can you tell me about that? So if they say they're coming in with weight loss, I will say something like, when did you last remember feeling well? And then I say, what has happened since then? Tell me everything you can think of that might be important. And it allows them to tell their story, most of it important, some of it may not be important, but that way I don't miss something. If a patient volunteers something, as opposed to me having to ask them, well, do you have abdominal pain? And they have to think about it. When they volunteer it, it's more likely to be real and important. After hearing their story, whatever they can volunteer, I shift to what I call the detective. This is where I am hearing what they've said and I think, based on what you have told me so far, there are a few things I'm thinking could cause this. Here are some specific questions to help me figure this out. So it explains to the patient that I've listened, but now I'm trying to be the detective to figure it out. And they like hearing that because they know they have a tough diagnosis to figure out sometimes. The last stage is what I call the data collector. And many of my students often jump to this first. where they have a long list of 100 questions they want to ask. What are your allergies, your medications, your family history? Do you smoke? Do you drink alcohol? All these questions. I'm not saying they're not important, but I challenge my learners to first listen to the patient, then try and diagnose, and then go to the routine history. And the reason for that is it really forces them to try and be thoughtful when they're trying to diagnose, and they sometimes get things in the data collector part that they then realize is important. What I found is if they do the data collector first, they may get all this information, but they don't understand the importance of it because they haven't actually understood why the patient is there. And so something I might say is, now here are some routine questions we ask everyone. That way they're not offended if I ask them, do they smoke? Do they drink alcohol? Do they do drugs they bought off the streets? A key thing that I'd like to point out is these three phrases. First, I would. Based on what you're saying, I have specific questions. And now here are some routine questions. We call this signposting. It gives the patient an understanding of each step in the questions. So instead of asking 100, do you have chest pain? Do you have a runny nose? Do you have abdominal pain? Do you have diarrhea? They can understand the first part was listening to them. The next part is me trying to think what they have. And the last part are some standard questions so that they're not upset if I'm asking them sensitive questions. I'm going to focus in on the detective part for the last few minutes of this talk, because I feel this is still something that many of my learners, not only my international medical graduates, but many of the Canadian trained still struggle with, is how do we, what framework do we apply to this part? And I call this the 3 C's. The first is to confirm what you suspect. And what I mean by that is, as the patient has started to give you an open-ended history of what brings you in, and they say, doctor, for the last 6 months, I've been feeling more out of breath when I walk up a flight of stairs, and then I've started to notice my legs are swelling. And so you think to yourself, this sounds like it might be congestive heart failure. I should ask other symptoms of congestive heart failure, such as, do you wake up at night out of breath? Do you find you're using more pillows? So the first step is confirm, asking the other questions that go along with your diagnosis. The next step is looking for the causes. Why does this patient, if they really do sound like they're in congestive heart failure, why have they gone into congestive heart failure? And this is where I'll ask questions like, have you ever been told you have high blood pressure? Do you see a doctor regularly to know if you have high blood pressure? Has anyone ever said you've had a heart attack in the past? Or are you getting any chest pain now? Thinking about why they might be in congestive heart failure. Another question is, do you ever feel your heart racing? Maybe they have a condition like atrial fibrillation that has caused this. Most of my learners can do the first one, and then as they get better, they start to do the second one. But it's this third C that people still don't ask, which is, what are the complications or the consequences of the illness? And that is both the medical complications and the what I call psychosocial complications. How is the congestive heart failure impacting them? So someone with quite advanced congestive heart failure may feel weak, but weakness is a very non-specific symptom. Many things make you feel weak, but the weakness, at least once I know they have congestive heart failure, it tells me how bad is it and helps me understand how it's impacting the patient. So then I might say, wow, you've had this for 6 months, your breathing's getting worse, and you're feeling weaker. And I understand you work in construction, building houses. How has this impacted your work? And the patient may say, I've actually had to quit my job and I'm now unemployed because of this condition. Whereas sometimes as doctors, we don't even ask that and we just try and diagnose and don't realize that it's impacting our patients. So you can see how this aligns with the patient-centered care model, We are trying to figure this out. We're trying to figure out how it impacts them. So I was just given 20 minutes and I think I'm on time. My summary is proper communication during history taking in medicine is very complex. There is no doubt about it. There is a dual process that is occurring, at least the way we teach it, it's occurring simultaneously. The physician is trying to diagnose the patient. The patient wants to ensure they are heard. Effective techniques such as signposting. First, I'd like to hear what symptoms you've had over the last several months. Now that I've heard that, I have some thoughts. I'd like to ask you some specific questions to figure out the diagnosis. Finally, I just have some routine questions that we ask everyone. Those are called signposting. And then as well as summarizing. So what I've heard from you is you've been short of breath over the last several months. You've gotten swelling in your legs. You're waking up out of breath. Occasionally your heart is racing. Oh, and sorry, I forgot to ask, are you having any chest pain? No. Okay. And my suggestion is to try the 3 phases of the history, explicitly listener, detective, data collector, to make sure you've exhausted the detective phase to really think through what could be the cause. And then try using the 3 C's, confirm, causes, and consequences, to figure out the diagnosis. Again, I must stress, this is something we teach over many months, over 2 years in our medical school. And there you have my 20-minute presentation on patient-centered care. Thank you.
Thank you very much for Professor Vijay Daniels. For those who are going to ask the question, please save the questions until the end of the sessions of all the speakers' presentations. Okay, now we come to the second speaker, Professor Dr. Diah Kristina, M.A. Ph.D. She is now working as a professor in Language and Cultural Studies at Sebelas Maret University, Surakarta, Indonesia. She earned her bachelor's degree from English Literature, Sebelas Maret University, and also she got her master's degree from University of Sydney, Australia, majoring Applied Linguistics, and successfully earned her doctoral degree from University Utara, Malaysia, majoring Applied Linguistics on 2011. She has published many research and books related to languages and literature, such as English for Mastering the Art of Online Promotions book on 2020 and Multimodal Branding of Indonesian Online Promotional Discourse in Hospitality Industries on 2018. She was awarded several honors from the President of Indonesia on 2018 and Ministry of Education and Culture of the Republic of Indonesia on 1990, and today Professor Dr. Diah Kristina, Ph.D. is going to present one topic titled Empathy in the Online Interviews of Doctor Patients, a Multimodal Perspective. For Professor Dr. Diah Kristina, Ph.D., the time is yours.
Thank you very much for a very nice and friendly introduction to the moderator. I'm waiting for the screen share of my PowerPoint that I have already sent to the. Okay, thank you very much. So here I'm going to talk about the empathy in the online interviews of doctor-patient, a multimodal perspective. But before that, I should express my gratitude first to the Director of Universitas Malahayati, Dr. Ahmad Farih, Magister Management, and then to Bapak Selamat, and one of my best students, Bapak Muhammad Rudy, whose effort and struggle has been successful to invite me to be one of the speakers. And of course, I would like to also express my gratitude to Professor Vijay Daniels, because he has opened up a road for me to continue his explanations through my PowerPoint presentations. Next, please. Yeah. The question is, why online medical consultation attract users? Yeah. There has been a very strong notion right now because the revolution industry of 4.0 digitalization of almost every single information management right now. Now we will look at the reasons why online medical consultation attract users. Next, please. Yeah, there are some reasons, yeah, why medical consultation online is attractive to many users. First is because of the economical reason, yeah. For instance, as participants of this webinar, we are able to join this webinar free of charge. We just, using our laptop, and we are able to communicate with many people, yeah. So this is very economical. And then secondly is privacy. Privacy is very important because when we are talking about health, we will we will explore so many things confidentially, yeah, that relates with our health, yeah. So that's why online medical consultation is considered to be more private. And the third one is a second opinion. So normally, whenever a patient has visited many doctors, they sometimes need to have the second opinion to make the patient feel confident about the real situation of her health or his health. Next, please. Now, why online medical consultation, yeah, attract users? Again, based on the statistics, among massive internet users, women 64.7% were outnumbering men, 35.3% in using it for consultation purposes, yeah, according to Edward. Female users whose age ranging from 25 up to 44 years. So women prefers, or female prefers to have online medical consultation. I hope this is not a threat, yeah, for the practitioners, medical practitioners right now. Next, please. Yeah, one thing, if we pay attention to the development of YouTube contents, I do believe that YouTube is actually a very good source for learning, yeah. Doctor-patient consultation in English on YouTube functions both as information resource for health and a model for teaching and learning, especially a course on medical interview. That is something that I am taking one of the model for discussion today. Next, please. Now, Professor Vijay Daniels has already mentioned in elaborative way about communication skills. Yeah? The question is, why communication skills needed by the doctors? Next. Yeah. Communication skills of a doctor in conducting medical interviews to his or her patients determine diagnostic precision. So only through a good communication skills that the doctor is able to dig out, to explore things that happen to the patients. Besides that, while having a good communication skill, a doctor is able to establish mutual doctor-patient psychological relations that lead to patient's recovery. So patient's recovery, to a certain extent, has something to do with a good communication skills that a doctor is establishing during the diagnostic session. Yeah. Next, please. And now the question is related to the title of my presentation. Why empathy? Why empathy is so important? Yes, next. I should mention 4 things here why empathy is important. First, what is empathy? Empathy refers to social behavior in which speech users show their concern, emotions, and encouragement. Second, what is empathy? Empathy is the ability to understand the thoughts, feelings, emotion, and most importantly is to listen to the patients. Next, Why listening to patient is very important? Because relationship listening between a doctor and a patient is also called or empathetic listening. It functions to support emotional engagement. Yeah. And empathy helps constructing pro-social behavior. That's according to Davis 1994. Next, please. What about empathy and patient's recovery? We will have a look on the next. Next, please. Yeah. Empathy and patient's recovery. Again, Professor Vijay has mentioned earlier that the relationship between a doctor and the patient is a relationship among or between two human beings. Doctors are facing human beings whose feelings and emotions determine patient. So the relationship, the engagement should be paid attention to, because our patient has a feeling to count on, to pay attention to. And empathy is one of the most powerful ways of providing support to reduce patients' feelings of isolation, frustration, and to validate their feelings or thoughts as normal. Because sometimes a patient comes to a doctor feeling that he or she is abnormal because of her health condition. And breaking bad news like, well, the patient has a cancer, for instance, is a complex communication task. It requires other skills, responding to patients' emotional reactions, involving patients in decision-making, and then minimizing the stress of the patients. Next, please. Now, what is the objective of the study? Yeah, there are 3 objectives that I am doing the study in my university. First is empathy, mainly delivered using verbal expressions. How would the non-verbal construction of empathy take its form of expressions? And the second one is, what constitutes expressing feelings empathetically? Bad news. And the third one is, how would a logic and imperative message a doctor needs to pass on to his patients be delivered effectively? Yeah. Next, please. Now, the methods. Yeah. I will run very quickly about the method. Yeah. These are things that I'm doing. So I'm trying to explore, to learn very closely 5 types of online medical interviews, especially under the title of delivering bad news, to see the communicative purpose, the rhetorical structures, and speech act realized verbally and non-verbally. Yeah, I'm looking at from the perspective of multimodality. Next, the verbal data include words, clauses, sentences of text in question, while the non-verbal data consisting of body language, facial expressions, pose occurring iteratively and consistently during the medical interviews, and details about medical discourse community of users. Next, yeah, and then the last one is I am doing the interview with 3 students and as informants, a doctor whose patients were foreigners, and a teacher. Also, she teaches while also developing a syllabus. Next, please. And how would I analyze the data? Yeah. First, I tape 5 online medical interviews, and then transcribing data using coding system, and then classifying the data based on their communicative purpose, rhetorical structure of text, doctor-patient relationship, empathetic verbal and non-verbal expressions. Next. Following after some phases of the data analysis, I also describe the community of users and their cultural context, doing componential analysis to identify patterns of verbal and non-verbal empathetic expressions. Unfortunately, I cannot present the patterns of verbal and non-verbal empathetic expressions very deeply today because of the time, and I'm writing it for the next publication. And then I'm using Spike's model of 6 protocols to analyze the 5 texts with genre perspective proposed by Sebelas and the multimodal theory of Kress and Luan 2010. Next, please. Yeah, so these are the following steps that I'm doing. Can I just go on with next, please? Yeah, now we come to the results and discussion, yeah, using the Spike's model, yeah. So what are actually the Spike's model? The Spike models consist of 6 protocols. The first is S stands for assessing perception, P obtaining invitation, I giving knowledge, K emotion and empathy, yeah, sorry, E for emotion and empathy, K for giving knowledge, I for obtaining invitation, S for assessing perception, yeah. S for setting, sorry, S for setting, yeah. And then the last S is for strategy and summary. This model of delivering bad news is an action-oriented a doctor should do to his or her patients. Because I'm doing it based on multimodality, so I am looking both from the perspective of verbal and as well as non-verbal. Yeah, next please. So here are the protocols and the linguistic realizations. Why I look at the linguistic realizations? In the context of Indonesian students, linguistic realization is very important because we are struggling with how would we construct the expressions for a specific speech act that we need. For instance, in setting up, yeah, what is done in setting up? We check information, we do introduction, we check the privacy, we also invite and recognize the significant other, so relative of the patients who are going together with the patients to visit the doctor, yeah. So Indonesian students need, how would I say that in English? How are you doing? Oh, hi, I'm Dr. Connie. Does your illness affect your activity? Is there anyone in the waiting room that you want to share with it? Yeah. Who wants to share with this? Yeah. Okay. Next, assessing perception. How would we do that to assess perception? Yeah. The previous one, please. The previous one. Sebelumnya, yeah. Assessing perception to what activities, what is it? Speech acts are done here. So checking how much is known. God's level of understanding. Yeah. How would we say that in English? Do you understand why we do the CT scan at this first place? Yeah. It's really unexpected that I'm sorry to have this. Something like that. Yeah. Next, please. And then with obtaining invitation, yeah, we respect relative or careers basis. Yeah. Would you like to tell you the details of what happened? Yeah. And then the giving knowledge and information, the next step, we can say something like when we give information in small chunks. Yeah. I'm sorry to tell you that your CT scan showed there is a spot. Yeah. So sometimes a doctor needs to not very clearly and openly and straightforwardly to tell the patient about what really is happening. Yeah. Not necessarily to hide something, not necessarily to be dishonest, but in the sense that the doctor is trying to save the patient's face and confidence. Yeah? Okay. And then for the emotions and empathy, acknowledge their feelings. Yeah? So a doctor needs to say something like, I can imagine how is your feeling, but I can assure you that I can provide the best medical care for you. Don't worry. Yeah? We doctors will work very hard for your recovery, something like that. So that is an empathetical effort that a doctor should express, and that needs communication skills. Next, please. And then the last part is the strategy and summary. Yeah, something like understanding patient's problems, explain next steps in treatment plan, explain what expected to happen, identify sources of support, something like that. So you can also have some examples on the linguistic realization. Yeah, I'm glad to tell you, I'm glad you tell me about your feelings. Yeah, and so on and so forth. You can have a look, and the committee will share my PowerPoint, yeah, to the participants so that you are able to look at it more closely. Next, please. Now the question is, why multimodal? Yeah, according to the theories that I'm reading, and also based on experience, the sound, yeah, the voice, yeah, that the doctor is producing when he is dealing with the patient will be able to boost confidence on the part of the patient. And the visual and touch can be helpful for engagement between the doctor and the patient. Next, please. Here, I would like to report what is going on actually in the field. Yeah, I'm sorry to my colleagues in the medical faculty. Yeah, this is not supposed to be exposing our defects, but we are trying to build and develop and improve our condition based on the research that I'm doing. Yeah, in the institution where I work, more works need to make as they do the medical interview in Bahasa Indonesia, yeah, Indonesian language, yeah. And they specifies in history taking model. This is not, there is nothing wrong with this one, yeah. But for empathy, I think history taking is not the only thing that doctors should be improved, yeah. The history taking requires the patient to be more active, yeah. Whereas the emotion and empathy pace of the spikes model requires more of the doctor to be active. They have to initiate, to elicitate, yeah, the feelings, the emotions of the patients, so that their diagnostic effort will be very accurate, yeah, and therefore it helps the recovery process. Next, please. And then this is the voice of the materials developer, yeah. One of the informants, the materials developer, mentions the following. Students have not even mastered the techniques of constructing questions to patients in terms of history of their diseases, socio-economic background, and family background as the medical interview course is given in semester 1. So there is a question again, yeah? Why in semester 1? In addition, these freshmen have not learned yet about the techniques of identifying symptoms and diagnosis. The digital materials intended to supplement the teaching processes were not yet completed. Next, please. And then again, realities in the field, I will add some more information about what is going on somewhere there. Next, please. Yeah. This is a comparison between classroom and examination room. Yeah, in the classroom, the material developer claims that the module is sufficient to promote medical students' professionalism in medical interviews. However, she confesses that teaching the module in English is challenging due to competence of the instructors. Whenever I ask one of my colleagues in Bali, yeah, so the teaching of history taking in Bali using English is no problem at all, because the the mastery of English in Bali, because of the exposure to foreigners, is much better mastered there. Yeah. While in the examination room, more senior doctors were reported by 3 informants as tending to be more direct in giving information concerning the patient's critical health in a more verdict-oriented statement. This is true. This is a report of one of the patients. Yeah, the senior doctor, for example, does not explain about the patient's condition. Instead, he assigns the patient to seek for the information in the Google search engine by herself. Next, please. Why empathy again? Yeah, and then this is another report. The young doctor that I visited many times explains very clearly my existing health condition, sometimes using special analogy with a more sympathetic and understanding responses. He even tries to encourage me to fight for the challenges bravely. So it supports the theory or the result of the research from Matteo, Halpern, and Clark. Next. Yeah. Informant 5 highlights about the sensitivity of the young doctor to her feeling. This is the informant is a female. Verbally, he has a better strategy to pass on information and avoids using expressions that may harm the patient's feeling and emotion. Next. Most complaints about doctors are related to issues of communication. This is supporting what Professor Vijay Daniels has explained earlier, not clinical competency. Yeah? Next. In terms of professional development, Informant 5 evaluates that senior doctors tend to occupy their status quo, yeah? And less updated to new medical research development and technology than their young counterparts. So this, I hope, is a kind of what is it? What should I say? Yeah, I hope this is an alarm for us, all of us. Yeah, and then the next is patient's experience again. Yeah. This is another informant who tells us about her experience. During my birth labor, I perceived that young doctors are more communicative and well-informed than their senior colleagues. I feel more convenient talking to them during their visit. The non-verbal clues that the young doctor employed were mainly facial expressions and eye contacts. Again, facial expressions and eye contacts are part of the non-verbal communication tools, which are very simple, but it's very important. It's very helpful to the feelings of the patient. Okay, so again, next, please. Yeah, these are my conclusions. Yeah. Speech acts to be mastered by a future doctor. This is the ideal things that teaching medical students should be done. Yeah, initiating patient to tell about his or her health and how deep he or she understands about their medical condition and to what extent he or she is ready to face health problems. Next. Yeah. Ask anything about his or her health. And then showing empathy to patients verbally and non-verbally by touching, by listening, by nodding, yeah, by having a very close distance between the doctor and the patient, and also informing about the coming plan and strategies of treatment, then concluding the consultation. I think that's it, my presentation. I hope I will be very happy to have the questions, and I am trying my best to answer all of the questions. Thank you very much. I return this to the moderator, the opportunity. Yeah,
Thank you very much for Professor Dr. Diah Kristina, M.A. Ph.D. Now we come to the third sessions with Mr. Muhammad Rudy, M.Pd. Mr. Muhammad Rudy, M.Pd. works on English for specific purposes fields, especially English for medical purposes and English for nursing. And he earned his bachelor's degree from English Department, Faculty of Teacher Training and Pedagogy of Lampung University on 2011. and he got Indonesia Endowment Fund for Education Scholarship from Ministry of Finance Indonesia to continue his master's degree from English Department of Sebelas Maret University, Surakarta, Indonesia. And his research interests include multimodal corpus, curriculum design, teaching methodology, and discourse. His recent publications are Measuring Spoken Vocabulary Load on Medical English Students, a Learner Corpus Evaluations, and the Analysis of Spoken Medical Discourse on OSCE Videos, a Multimodal Corpus Approach. And today, he is going to deliver a topic with the title Multimodal Corpus Approach to Begin Medical English Teaching for Mr. Muhammad Rudy M.Pd. The time is yours.
Well, thank you. Does it work? Well, thank you very much, Miss Moderator, for the very nice introduction. And first of all, I would like to provide my gratitude to Prof. Vijay Daniels and Prof. Diah Kristina for the participation and the contribution in this seminar. Both of your topics enlightened us. It brings a very deep understanding and broad-minded about the communication in the medical setting and how to implement it in our activity, especially in Balai Bahasa Universitas Malahayati, when we are having medical English classroom program. Here, I would like to share my slide first. Okay. Here, a multimodal corpus approach to begin medical English teaching. Actually, it is based on my research and also my practical experience. So hopefully it will help you to understand or bring you something new or understanding about teaching medical English. Here, it is kind of a contemplation for us that it is our experience in learning English. It is not about medical English only, but also general English, like English for communication or English in the school or the campus, like that. So have you ever memorized a vocabulary that your English teacher asks you to make vocabulary list, tens or hundreds, and then you need to memorize them? And at the end of the class, you find yourself remember very few words. Even when you remember some words, but you do not use it every day. Take for example, the word lion. My English teacher when in the elementary school asked me to memorize lion. But I know lion, but I rarely use lion word to communicate or use it in the class or write it in the classroom. Take for example, my lion is sleeping beside me. We rarely use that word in our daily communications. That's the experience. So why don't we learn things that is daily useful in our life, like the word turn or get? Take for example, almost every day we say, I turn my TV on, or when we go to barber shop, I get my hair cut, something like that. So turn and get is in here is more frequent to be used or commonly used by people rather than the word lion. This is the depiction that I'm going to present. As students, as the experience of the students, we need to learn language that we can use every day instead of occupying our brain memory with less practical things or words. Like in general English classroom, English instructors in the medical English need to be careful bringing their material to the classroom. The teacher or the instructor of medical English need to ask himself or contemplate that will the material be useful for the students in the future? Something like that. So here for designing materials in the medical English classrooms, we can start from needs analysis. There are two types that I know, that is needs analysis or vocabulary selection. Needs analysis means that we seek the information from the students or other parties related to what kind of English is needed by our students in the future. The other method to create the materials is vocabulary selections. I can say it is corpus analysis. Let me give the example. The word abdomen, stomach, and belly. They are similar in the meaning. It replies that it is part of our body, abdomen, but which word is commonly used in the communication, especially for medical English students when they meet or talk to their patients. So this is the are we as the English teacher really sure that the students will talk with the patient using abdomen, or they choose stomach or belly, even though those three words are similar? Okay, here I give you a brief information about corpus. Corpus is a collection of text. Okay, like on my slide right now, corpus, compilation of spoken or written text stored in a computer. In the very simple definition, corpus is a collection of text, but later on, corpus analysis or corpus compilation is stored in computer. Why corpus? Because corpus can bring or give the samples of real language use. As an approach, corpus linguistics is aimed to analyze and describe language use as realized in the text to create meaning. The corpus itself more working on the frequency and patterns. The frequency and patterns can be used as the materials in our medical English classroom. Well, those two previous speakers, Professor Vijay and Professor Diah, has gave us information about patient-centeredness and multimodality. If we go back to the previous slides, corpus merely about the words, but in here, in teaching, based on the information from Professor Vijay Daniels and Professor Diah, we need to provide materials for the students, not only words. We need to bring gesture, expressions, even the voice or intonations and other aspects in the communications. That's why, as a medical English teacher, we need to create or build the materials that fit those aspects. So here, later on in my following slides, we will find how to get the output of the material or materials to be prepared in the medical English. It is the materials that provides verbal and non-verbal aspects. The verbal can be like words utterances or phrases that is useful in the daily communication of a doctor-patient's encounter. And then the non-verbal aspects related to voice, gesture, expressions, etc. That is I can summarize, it is the multimodal corpus approach. First, when we try to build the material, first of all, we need to select videos that can be used, that is available on YouTube, that is OSCE videos, objective, structured, clinical examination. In this examination videos, we can see various types of communications between doctor and patients, whether it is during the history taking, or examinations, or giving diagnosis, or asking concern to the patients, something like that, so that we can have one of the source that OSCE videos is useful for teaching our medical students. And then the second stage of creating the material is make script and annotations through ELAN software. The annotation software that I use is ELAN. Actually, there are many types of annotation software, but one of the most preferred and revered software is ELAN. ELAN is a Udico-linguistic annotator. Udico stands for European Distributed Corpora. It's a professional tool for the creations of complex annotations on video and audio resources, which is available to download free. Okay, so for teachers, when you want to use this what is that? The software, you just go to that website and then download it for free. The last stage that to build the material is calculating the frequency and patterns. But as a teacher, we don't have time to calculate the words, thousands of words, and categorizing which one is the best word to teach in the class, something like that. Because we have Wordsmith tool, is a corpus tool, but unfortunately this one is not for free. But actually there are other tools that is free, like Nkong or Nkong and others. Okay. Next is here the examples when we search on YouTube. One of the most referred videos or videos is the Edmonton manual. It is performed by Professor Vijay Daniels, and I did a little research on this because in here there are 9 videos starting from the COPD, OSCE, or examinations and communications goals with the patients, sleep apnea, and others. And then here is the preface of the ELAN. When we have downloaded the videos, when we have downloaded the videos, we can analyze it through the ELAN software. We have here video viewer, annotation density, so we can create the transcript for the doctor and the patients. We type the words or the phrases stated by the doctors and patients here, and then other aspects like gesture, phrase, voice, and others. This is how to find this this ELAN software is useful to categorize the non-verbal aspects. Okay. Okay, this is the sample of the ELAN. Here.
Last year. And then I'm a teacher, and at the end, I thought it would go away.
Okay, this here.
Like, if it's affecting you, that's absolutely great.
You see the gesture of the doctor and the word that is stated by the doctor here, like that. Okay. Okay. Wait a minute. Okay, wait a minute. No. Yeah, this one. Okay. Sorry. Here is the sample of the analysis on the ELAN software.
You know, like, if it's affecting you.
Okay, we can see the gesture and the word stated by the doctors to convince the patients. The setting is communication sleep apnea. The patients came to the doctor and asked many things. Then we can observe the voice, intonation of the doctor, something like that. Okay, and then continue. Here is the result of the ELAN analysis. We see what the doctor said. Even we can know microseconds of the utterances of the doctor, and like saying, and you are Mr. Hansen's, right? Like that. Okay. Like this. And Vijay Daniel introducing and others. And here, from the 9 videos that we learned or we downloaded, we can see that there are 18,524 words produced by the doctor during the conversations. So, finding one specific word that is need to be brought to the medical English class from 18,000 something words is really difficult, right? That's why we use this software, namely Wordsmith. In the Wordsmith, we can analyze the concordance, keywords, and word lists, and others. Okay, so we can put the type script and then find what words that we need to teach to our students. After the analysis through the Wordsmith tool, we can see that here is the rank of the words. The most word that occur in the conversation is the, but should we teach the to our students? Therefore, we can go to the next stage of analysis, that is keywords analysis. After the keywords analysis, will show you the specific words that is very relatively or specific, that is reflecting what's the identity of the conversation. The word that plays the highest rank is okay. here. And then the other word is stethoscope. Like that. We can compare that the word okay has a bigger effect or impact on the conversation between doctor and patient rather than saying stethoscope like this. Okay, so these are the 20 most keywordness of the word in the conversation, but the one that plays the highest rank is okay. Why should be okay? When we click the word okay, we see that the doctor stated okay for many times. And then when we go to the context, here is the sample of saying okay. The doctor state okay like this here. So actually that's actually testing color seems to be okay. Okay, like that. But the other okay is this, and the response of the doctor is this. Okay, is look at the door over there. Okay, the doctor asks the patients to look on the door, look at the door. After that, when the patients did the instruction from the doctor said okay. Here, when saying okay, in other contexts of conversation, the doctor use a body gesture, nodding head like this, okay, while saying okay. Okay. So the word list or keywords, utterances, and videos are things that we can bring to our medical classroom when we have finished or understand that some terms or some words are specifically used in the communication between doctor and patients. So it will valuable to teach our students with the word list or the keywords that or utterances based on the sample from the doctor conversations. Here are the examples of the utterances after we did the analysis through the wordsmith. Here, the three words that mostly found in the conversation: can you feel, can you please. This is the way the doctor instruct the patient. Can open your, can relax, can you feel, do it just, do you see, something like that. And the four words are going to be listening, if you could please, if I was really. That's the utterances that's important to be brought in a medical English classroom. Go to the 5 words utterances or cluster. If I could ask you, if I pull down your, can you please close your eyes? Can you feel the vibrations? Something like that. Or I'm going to ask my patient, going to pretend that this patient, and so on and so forth. Okay, and we can see the videos that has been cutted. Here, the sample of the videos that is useful to be brought to our classroom is like discourse so moving.
In drawing, and I don't appreciate any of that. So moving on to auscultation here, this is when I would do a forced expiratory time. 5 years.
Wait a minute. Where is the video? Okay. Okay, here is the sample.
In drawing, and I don't appreciate any of that. So moving on to auscultation here, this is when you I would do a forced expiratory tone.
Here is this
in drawing, and I don't appreciate any of that. So moving on to auscultation.
So moving on is kind of a discourse marker based on our linguistic analysis. So moving on, kind of a part of the speech to show the sequence of the communication, what's the next step or the next stage that will be done by the doctor.
5 years.
I've gained some. I've gained weight. I'm in my 50s. I'm just.
So this is kind of an interactive gesture. The doctor didn't say anything, but the doctor nodding heads for many times.
They're a little aggressive, and one is, have you ever heard of BiPAP?
I don't think so.
Okay, and the substitute relations.
Brought it to JVP. I'm going to move to the precordial exam. Do you mind if I lower this?
Yeah.
Okay. The doctor said, would you mind if I lower this? This one of the things that can be taught in the medical English classroom, that they need to show politeness, because Hedging's utterances is claimed to be more polite than asking your patients, I will lower this, like that. Okay. There are the samples of the videos that can be brought to our medical English classroom. Okay. The next is my summary. Preparing materials for medical English class should consider about patient-centeredness and multimodal aspects. So, because medical students should be trained to build a rapport medical encounter, so they need to make it as a habit having a rapport medical encounter. So multimodal corpus approach enables the teacher to bring verbal and non-verbal aspects to the students, so that the students will be common with the verbal and non-verbal aspects they perform in the future. They are my presentations, and this is the further reading. You can read. The materials will be shared. And thank you very much. Go back to moderator.
Thank you very much for Mr. Muhammad Rudy. Now we come to the next sessions, which is the sessions of questions and answer. I have read some of the questions given from the participants, and I'd like to choose the first terms consists of only 3 questions, and I will randomly choose the questions. The first question is coming from it's coming from Dwi Widiani. Sorry, it's the first question is coming from Novia Nur Ikhlasia from SMK Negeri 1 Pulau Besar. The question is for Professor Diah Kristina and also for Professor Vijay Daniel M.D. The first question is for Professor Diah, is that what application did you use to collect the data shown in your presentations? And then the second question from Novia Nur Ikhlasia is for Professor Vijay Daniel, what are the general topics you suggest to be taught to medical vocational high school students? For Professor Diah and also Professor Vijay, maybe you both can answer the questions. Thank you.
Okay, who is supposed to be the first speaker to answer the questions, please? Okay. If the first opportunity is given to me, thank you to Novia Nur Iklasia. So in collecting all of the data, some of the data were collected from YouTube, yeah, especially the online interviews, yeah, about delivering bad news, yeah. What I am doing with that data, 5 interviews from YouTube. First of all, transcribe, and then after transcribing, we are concentrating, selecting parts that relates to empathy only. Yeah, so expressions showing empathy are collected, and then we try to analyze the expression and realization of empathy in the form of linguistic expressions. Yeah. After classifying, then we try to use the materials, yeah, see it from the map. So we map out the phenomena of expressing empathy. After that, we try to draw conclusion, yeah. And then for the other interviews, we are doing it ethnographically by doing some observations on the field. And also we are using chat of the WhatsApp and telephone calls, yeah, to collect information during the interview with our informants. I hope the questions from Novia. Thank you, moderator.
So in terms of what to teach medical vocational high school students, it's an interesting question that may be more specific to how things work in your country. In North America, we've had a shift over the last 20 to 50 years where we used to want people with a heavy science background to come into medicine, but now the shift has been, we will teach all the science you need in medical school, and we are actually looking more for well-rounded students. So we take students from a variety of backgrounds. Most still come from science, but we have students from an arts degree, fine arts, music, drama, phys ed, like lots of different backgrounds. So it depends on how it works for you. I personally did a lot of sciences, physics, biology, chemistry in high school. In my undergraduate degree, I did biochemistry, but I actually had a double major in math, and I also did almost a minor in philosophy. And I think that's part of what we are moving towards in North America is a well-rounded sort of physician. And maybe I'll use this as an opportunity to say, part of what I think is key with some of the other questions around how do you quickly develop rapport, it is the hard to teach skills that somehow go along with someone who's well-rounded. If you've worked in, my first job was a janitor cleaning at a pharmacy, and then I worked at a grocery store bagging groceries. That taught me a lot about how to be patient-centered. I know that sounds odd, but you deal with people a lot, deal with customers. And so I think although the subjects of science are obviously important in medicine, it's beyond that. Hope that answers the question.
Thank you very much for Professor Diah and also Professor Vijay. And then for the next questions is coming from Dwi Widiani, a medical doctor, project consultant. She asked for Professor Diah, Kristina, the question is that what is the impact of using closed questions, yes or no, in online consultations? I observe most of my doctor colleagues tend to use that when to talk to the patients online due to short duration available.
Yes.
Thank you very much.
Thank you very much, moderator. I would like to answer the question from Dwi Widiani. Yes, I can understand why the doctor tends to answer very shortly using yes or no answer. And of course, there are some reasons to do that. First is because of the time, yeah, duration in the connection, and as well as it will have something to do with the financial expenses probably, yeah, because of the internet connection. And also, of course, when you want to go much deeper, internet consultation or online consultation is only one of the alternatives. For a much deeper information collection or information gathering, of course, face-to-face visit to a doctor is always better. But to seek for the second opinion, internet interview with the doctor, I think is not always a bad solution. I hope I can answer the question from Dwi Widiani.
Thank you very much for
Moderator, could
okay. I'm sorry.
Could I also add? Could I also add to the answer?
Yes,
Because
sure.
I think it impacts other questions on busyness. And I think, as Professor Diah, Kristina said, part of it is the context of being online with time constraints is going to change behavior, and that's neither right or wrong. That's just reality. But as she said, and I agree with her, that if we spend the time with our patients, if we can, avoiding too many yes/no questions can help with the diagnosis. I have found times where my learners want to very quickly, because they're busy, ask the yes/no questions, and then they're not sure of the diagnosis. And I walk in and just ask like 3 open-ended questions, and the patient tells me this beautiful story, and the diagnosis is so obvious. Now, that doesn't happen commonly, but it does happen from times. But they're working at 3 in the morning, they're sleep deprived, they're working quickly. I'm coming in the morning, I have a bit more time. So there's reasons why the yes/no may be used. Those are good reasons. A bad reason is true laziness, trying to take shortcuts. And sometimes what we're also trying to do is force the diagnosis on the patient. We think it's something and we're trying to ask the questions that'll make it that, whereas asking broader can actually get at the real answers, which sometimes leads you to be more confused because you're not sure, but a good doctor has to be confused at times to ask questions.
All right, thank you very much for Professor Diah and also Professor Vijay Janels. And then we come to the second session, consists of only 3 questions, and I will randomly choose the question from the chat room, from the participants. The first question is coming from Chandra Swari from Yogyakarta State University for Professor Vijay Daniels. She asked, since the consultation time is limited, how do you use and show empathy effectively to the patients without making it too long? Thank you.
It's a very good question. And this is where it's more the art of medicine. You develop those skills over time. There are times I'm walking onto the ward and I can tell that although my learners have done a good job, there's a situation where the family is not happy with the care they've received. I walk in the room, it's the first time I'm meeting this family. And again, it's part of that, having worked as a doctor and other jobs, you can very quickly get a sense of the situation and you know what needs to be said. Sometimes, and it's hard to answer the question because some situations, the patients want you to be quiet and just listen. Other situations, the patients want you to take command of the situation. And every situation's a bit different. Patients understand when it's an emergency and patients understand when it's a short consultation. But if you preface it as, we only have 10 minutes, my understanding is this is your complaint, I'm here to help you. So I'll be asking you a series of questions. And then you can go quickly with the yes/no questions. And then when you hit something where you realize, oh, this is impacting their life, you slow down for just 5 seconds, acknowledge it, and you continue. Hopefully that was helpful.
Great. Thank you very much for Professor Vijay Daniels. Now the second question is coming from Joe from Universitas Muhammadiyah Surakarta. He addressed his question to Professor Diah and also Professor Vijay Daniels. Do you have any suggestions on how to convince the patients that we do really care about them? particularly those having negative thoughts about doctors and refusing to provide information. Thank you for the enlightening presentations.
Shall I go?
Okay.
Well, if they've had negative feelings about doctors, that usually stems from previous encounters, because no one's usually born automatically not liking doctors. So I usually try and get at why that might be. And one of the key things, as I said, it was a confusing psychological term, but just assuming the best of your patients in the sense of, I offer the treatment, but I say to them, this is your choice. If today you decide not to, it doesn't mean I'm not going to turn you away from clinic. I will see you again. And sometimes it takes multiple visits where they say no, 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 for them to realize he's not giving up on me. And so then they can open up. In terms of the part if they're refusing to provide information, that's a little bit tougher. It's again trying to understand why they would be refusing. Sometimes they're there with their spouse and there's something they don't want to share. So getting other people out of the room. But if it's just a one-on-one and they don't want to talk, again, I find pushing the issue almost never helps.
Okay. Yes. I'm going to add some more information that Professor Vijay has already mentioned earlier. I know this is going to be very hard for the doctor, but again, I think whenever there is a possibility of a patient is not willing to tell about his confidential informations about his health, I think it has something to do with the trust. Yeah. So how the doctor get the trust from the patients? It can be done from the perspective of repeated contacts. Yeah? Whenever the doctor is having repeated contacts, then bit by bit, he or she will get the trust from the patient. And also the communication skills. One of the communication skills that the doctor should master is the investigative ability. Yeah, the investigative ability. I do believe that whenever there is a trust from the patient, there will be a good engagement between the doctor and the patient, and there is a very close engagement, and from that I do believe information from the patient will be able to acquire, yeah, by the doctor. I hope I can answer the question.
Thank you very much for Professor Diah and also Professor Vijay Daniels. And then for the third questions of these sessions, but I would like to remind you again, if you are going to ask several questions to Professor Diah, Professor Vijay Daniels, or Mr. Muhammad Rudy, you can type your questions on the chat room, or you can just tell me that you are going to give the direct question. So I will call your name and then you will ask directly to those speakers. Okay, so the third speaker from this, the third question from this session is coming from Erna Adita from Stikes Mitra Husada Karanganyar. If we talk about ESP, particularly for medical field, mostly it deals about English for doctors, nurse, and midwifery. It rarely discusses about English for medical record or English for health information management. Would all the speakers kindly give us suggestions and insight dealing with it, the materials, and also the methods of teaching? So this question is actually from Mr. Muhammad Rudy for Mr. Muhammad Rudy for Professor Vijay Daniels and also for Professor Diah Kristina. So maybe Mr. Muhammad Rudy may answer the question first and then followed with Professor Diah and also Professor Vijay Daniels. Time is yours.
Okay, thank you, Ms. Muhammad. Okay, related to ESP, actually ESP is based on the needs of the learners, what will they face in the future. So mostly medical English talk about the doctor and patients communications, and rarely talk about English for medical record or English for health information management. It is the materials actually, when we want to do this on the English for medical record or medical health information management, we can do the corpus analysis, like we search the text from the internet or books related to how to write down the medical records or other things, because medical records may be full of the terms, specific terms and others. We can use the corpus approach to find to bring what kind of materials that can be brought in our class, something like that. Like what I did on these videos, one of the keywords is okay can be brought in the medical classroom, because the purpose of my classroom was for communications. Of course, medical doctors need to be able to communicate. But when the purpose of the classroom for the medical record, of course, we need to have the sources first, the collection of texts that provide information about how to create medical record and others. After that, we make it in the corpus analysis and make some ranks or the list. These words are appropriate for the medical record or not, and then we select it carefully, then teach in the classroom. That's my suggestions. To the next presenter, speaker, please.
Okay, I'm trying to assist Erna. Since my background is on ESP and discourse, yeah, I would see it from the perspective of discourse as well, in which my suggestion would be you find the strategy of modeling. Yeah, I think I support Pak Rudy's explanation right now. You try to find out in the internet some models of the English for medical record and English for health information management. And then from there, I think the focus would be on the writing skills, yeah, writing ability. First, of course, you have to get the analytical. What is the most important thing that should be mentioned in your English for medical record as well as English for health information management? And then the strategy, in my prediction, would be how to describe, how to explain, how to provide evidence and things like that. And then the next thing, which is very important, is how do you order your thoughts? Because organization of thought is very important. This is reflected from the choice of discourse markers, like first, then, afterwards, after some examination done, then, and so on and so forth. And then when you close a certain record, you will say, in conclusion, to conclude, finally, and things like that. I hope I can answer your questions, Erna.
And to build on that, whether it is a handwritten chart or whether it is a computer-based electronic medical record that our hospital just moved to last November, there's the first part that's just the itemized data, and that's usually fairly straightforward, and probably your medical English you would have been taught. You get to the physical, head and neck, you would write stuff. But I think to what Professor Diah said is, there is the synthesis that needs to happen at the end of a consultation. That is something I've tried to teach. I used to teach it a lot more earlier, where instead of as a consultant answering a question, instead of just saying pneumonia or heart failure or cancer, I am summarizing with, this is a 55-year-old female presenting with 3 months of weight loss with postmenopausal bleeding that is highly suspicious for an endometrial cancer. And so it summarizes the case into 1 or 2 sentences. I'm not sure if that's what the question was about, but those are my thoughts.
All right, thank you very much for the speakers for answering the question from Miss Erna Adita. And then the next session is still question and answer is coming from Mr. Shafiq. He is going to ask their questions to the speakers. Mr. Shafiq, time is yours.
Well, thank you very much for the chance given to me to ask direct questions to all presenter in this occasion. Actually, yeah, actually for the first questions to Prof. Diah, Bu Diah. Actually, we are here, me myself, Shafiq Arisandi, as one of the committee of this online seminar. Wants to ask a basic question, a common question actually. As an English teacher, actually, there are some questions coming from our students related to English for specific purposes or medical doctor or medical classes. So do you have a basic competence related to medical knowledge? So meanwhile, my basic is English teacher, English lecturer, then they asked me about that one at that time. So the question is, who is the most appropriate lecturer or teacher to teach ESP classes actually? So that's the first questions to Prof. Diah actually. So based on your experiences, how to deliver some information related to that one to our students actually, because some doctor in our university actually sometimes do not understand about our activity at Balai Bahasa to teach medical students, and we are trying to teach about medical cases related to the examination from head to toe, and our basic competence is English, and they don't understand about that one actually. So who is the most appropriate teacher or lecturer to teach ESP classes, especially for medical or nursing classes like that? Thank you, Prof. Diah.
Thank you very much, Pak Syafiq, for the question. Yeah, I would like to talk from the ideal perspective. Yeah, ideally, team teaching is always the best. The team teaching consists of medical practitioners and English teachers because they are able to work together. Yeah, the medical practitioners will provide information on the real activity of the doctors, while the English teachers would provide information about how to say it in English, how to pass on information using a good communicative skills, yeah, and things like that. But in reality, it doesn't go that way. In UNS, for instance, in the university where I work, teaching English for the medical students is done by doctors. Yeah, unfortunately, it is done in Bahasa Indonesia. So, and mostly is history taking. Yeah, well, for M.Pd, history taking is not enough. There should be additional skills needed. Yeah, like digging out information, not only digging out information, but also to pay attention very closely to the emotion, listening ability of the doctors, to the problems of the patients, and so on. So again, it's very dependent on the policy of the university leaders. Yeah, if we are talking about the ideal practice, team teaching would be my suggestion. Thank you very much.
Thank you very much for Mr. Shafiq and also for Professor Diah Kristina. And then for those who are going to ask questions to the speakers, you may ask the questions. Or you can just continue to the next sessions. Okay, I would like to remind for all the participants to fill out the attendance list, which has already been given on the chat room. So you can just scroll up and then just fill out. And also, this is the session for the documentation. So please, for all the participants, you have to put your video on so we can see your face and then we can take the photographs. There are 6 pages because there are a lot of participants today. So there are 6 pages, and then we are going to take 6 photos. So you have to like smile for 6 times. Okay. So I would like to check first whether participants already put the camera on. Okay, so. All right. Okay, so 1, 2, 3. Udah. Okay, and then next. Wait. 1, 2. So I'm still waiting for those who are not put their video on. Okay, so okay, 1, 2, 3. All right, the third one. 1, 2, 3. Okay, the fourth one. 1, 2, 3. The fifth one. 1, 2, 3. And then the last one. Last but not least. 1, 2, 3. All right, thank you very much. Okay, thank you very much everyone for all the participants, and then thank you very much for all the speakers for enlightening our mind and perspectives about medical English. And I'm going to give it back to our host, Miss Vita. I will give it back to you.
Thank you to all the expert speakers. What an amazing session and very useful for us. And also thank you to Ms. Intan as moderator. Ladies and gentlemen, finally we get to the last part in this event, is closing. Let's close this event by saying Hamdalah. Now we come to the end of this event. To all the expert speakers, the committees, and all the participants, we would like to extend once again our deepest appreciation to you all for your support in participation. Ladies and gentlemen, I am Vita Lestari Ayunisi as Master of your ceremony. Even guiding this event, I made mistakes or offend someone here. Please forgive me. Thank you. Good day. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
See you next time, Vijay and Prof. Diah.
Yeah, thank you. Bye-bye, everybody.
Thank you very much for the talks.
Yeah, thank you.
Thank you very much.
Thank you very much.
Thank you.
Thank you.
Okay.
We'll see you, Mohammed Rudy.
See you.
You all.